Hey guys, so today we will be talking about the sympathomimetic toxidromes. So there are four sympathomimetic toxidromes. These are Serotonin Syndrome, Neuroleptic Malignant Syndrome, Malignant Hyperthermia, and Anticholinergic Toxicity. We'll be going through what causes each one of these, what are the distinguishing features, and how to treat these conditions as well. Okay? So let's start with serotonin syndrome. So serotonin syndrome is commonly seen in antidepressant use, for example. So when two antidepressants are combined together sometimes, such as an SSRI and an MAOI, so a monoamine oxidase inhibitor and a selective serotonin reuptake inhibitor, when they're combined, for example, they can predispose to someone developing serotonin syndrome. There's an increased surge of serotonin going through the system. Okay, so with serotonin syndrome, usually the onset is within less than 24 hours, okay, of the inciting agent, less than 24 hours, okay, and the resolution as well is less than 24 hours. So the onset is less than 24 within 24 hours, and resolution within 24 hours as well. Okay, what are some of the features you can recognize serotonin syndrome through? The history is very important, so watch out for antidepressant use, and sometimes other medications such as tramadol can also cause serotonin syndrome as well. Okay, so be very careful. And obviously, rarely, these are rare tumors. Carcinoid tumors can cause increased serotonin secretion, which can cause an increased levels of serotonin in the body. Okay, so watch out for this. So with serotonin syndrome, the features you're looking for are things like hyperreflexia, okay, myoclonus, okay, diaphoresis, okay, flushing of the skin, and you're looking for dilated pupils as well. Okay, you're just excited, okay, excited. And it can cause diarrhea as well. Okay, so these are some of the features of serotonin syndrome. Now, once you've recognized it, now it's time to treat serotonin syndrome. So serotonin syndrome can classically be treated with benzodiazepines, okay, benzodiazepines. And sometimes you may also use cryoheptadine as well. So either benzodiazepines or cryoheptadine. Okay, so now coming to neuroleptic malignant syndrome. With neuroleptic malignant syndrome, it's classically caused by antipsychotics such as haloperidol, your typical antipsychotics. So the way I remember the difference between neuroleptic and malignant hyperthermia, so they can present similarly. So how do I remember which one is which and not get confused as to whether antipsychotics cause neuroleptic malignant syndrome or malignant hyperthermia? One of the antipsychotics that is commonly used is olanzapine. So if I think olanzapine and neuroleptic, okay, if I keep that association, I can remember that antipsychotics are the ones that cause neuroleptic malignant syndrome. Okay, so antipsychotics, that's a key over here. Okay, antipsychotics. Okay, so the onset takes a couple of days to weeks for symptoms to start to appear. So as we saw in serotonin syndrome, this is within hours, whereas in neuroleptic malignant syndrome, it's days to weeks, okay? And resolution takes days to weeks too. So this is pretty easy to remember at this point, okay? Days to weeks as well. Now, classic feature of neuroleptic malignant syndrome, you will see on the, on the question, for example, you may see lead pipe rigidity, okay? Lead pipe rigidity, okay? So lead pipe rigidity is very important. In contrast to serotonin, you may also see hyporeflexia. So in serotonin syndrome, you were seeing hyperreflexia, where everything's excited. Okay, serotonin equals excitement, and to calm them down, you need to give them benzodiazepines. So in this case, neuroleptic malignant syndrome, you'd see hyporeflexia, not hyporeflexia. Okay, that's another key as well. With neuroleptic malignant syndrome, there are treatments that you can use. Okay, so there are two treatments you have to keep in mind. One, which is the main one, is dantrolene. Okay, dantrolene. Okay, and the second one you have to remember would be bromocriptine. Okay, bromocriptine. Okay, so this is a sort of highlighted version of how to identify neuroleptic malignant syndrome in a question or in a patient. Now, with regards to malignant hyperthermia, malignant hyperthermia is commonly caused by anesthetic agents. Okay, anesthetic agents. So what anesthetic agents are commonly implicated in this? So one of the main ones you might see is succinylcholine. Okay, so succinylcholine, and sometimes inhaled anesthetics. Okay, so inhaled anesthetics can include things like halothane, sevoflurane, for example. These are examples of inhaled anesthetics. Okay, so the onset is within minutes. Okay, so just think of something. Think of this: if a patient's in the operation theater, and before the surgeon starts the procedure, the anesthesiologist would inject anesthetic medications to the patient, and the patient would be unconscious in a couple of minutes. Okay, then all the breathing and everything's regulated by machines. So within minutes is the onset of malignant hyperthermia. Okay, and it takes 24 to 48 hours to resolve. Okay, it takes 24 to 48 hours to resolve. Okay, so one of the key distinguishing factors here is the history of use of having anesthetic agents administered to the patient. That's one. You will see muscle rigidity. So you can sometimes watch out for a keyword which says masseter muscle, which is your muscle that you use for chewing. Masseter muscle rigidity. Okay, that's one other thing you can watch out for. Okay, with the laboratory investigations or the signs that they may show you, you may also notice there's an increased end tidal CO2. Okay, end tidal CO2. Now, treatment for this, dantrolene. Dantrolene is very important in this case. Okay, in neuroleptic malignant syndrome, you have two options: either dantrolene, which is the preferred one, or bromocriptine. In malignant hyperthermia, you have a single option, which is dantrolene. Okay, so now let's move on to anticholinergic toxicity. So anticholinergic toxicity is commonly caused by things like antihistamines. Okay, antihistamines, caused by tricyclic antidepressants. Okay, now tricyclic antidepressants, they have their own toxicity as well. Okay, and this is important to note. You can remember the 3 C's. Okay, 3 C's, which are cardiac arrhythmias, okay, convulsions, and coma. Okay, cardiac arrhythmias, convulsions, and coma. So anticholinergic toxicity can be caused by antihistamines, TCAs, tricyclic antidepressants. It can be caused by atropine, okay, and it can be caused by anti-Parkinsonism medications as well. Okay, so anticholinergic toxicity can be caused by antihistamines, tricyclic antidepressants, atropine, and anti-Parkinsonism medications. Okay, the onset is within less than 24 hours. Okay, and resolution depends. Okay, resolution depends in this case. Okay, now what are some of the signs you will see? This is very important. So in regards to the signs of anticholinergic toxicity, okay, you will see dry, flushed skin, so dry. You will see urinary retention, okay, and you will see decreased vowel sounds. Okay, so for me personally, when I go through anticholinergic toxicity, I look at the offending agent. Okay, I look for an offending agent, and sort of the key feature that stands out to me is you use a medication and the patient ends up with urinary retention is one of the features that stands out to me after the administration of a medication. But it is important to know that symptoms such as dry, flushed skin, decreased bowel sounds, and urinary retention can occur in a patient with anticholinergic toxicity.